is the latest in research in spondylitis research, presented by Dr. John Reveille. It's my pleasure to introduce him. As many of you know, Dr. Reveille has a long history with SAA and with spondylitis research. He served as the director of the North American Spondylitis Consortium from 1999 until 2004. And since 2006, he has served as the principal investigator of the NIH-funded program project on the genetics of spondyloarthritis. Dr. Reveille is also a co-founder and member of the executive committee of the Spondyloarthritis Research and Treatment Network, also known as Spartan. And Dr. Reveille has also served on SAA's board of directors since 2007. So welcome, Dr. Reveille, and thank you so much for taking your time and sharing your expertise with us today on this subject.
I'm going to be talking about some of the research in spondyloarthritis. Let me just introduce myself. I'm John Reveille. I'm the Chief of Rheumatology here at the University of Texas Health Science Center at Houston. I've been working in spondyloarthritis most of my career, and I've actually been working with the Spondylitis Association of America on their medical advisory board since the medical advisory board was started in 1987. So I've been around a long time. I'm going to present today just certain aspects of the research. Obviously, some of the stuff that we're doing in genetics, also a bit on the epidemiology, and some of the work around the genetics, why the genetics are important. And then I'm going to end up by talking about some of the new treatment things that are coming down the line. Because we've actually, in addition to doing the genetic research, we've also been heavily engaged in the new treatment studies, and so we're very well acquainted with that, and we have more coming down the pike. So let me just move forward here. This now, ankylosing spondylitis is one of a member of a spectrum of disease called spondyloarthritis. Let me go back here. And that includes AS, acute anterior uveitis, undifferentiated spondyloarthritis, psoriatic arthritis, the arthritis associated with inflammatory bowel disease, juvenile spondyloarthritis, and reactive arthritis, which we used to call Reiter syndrome. Then we found out that Hans Reiter was not the first guy to describe it. In fact, if you really want to know, the first description was a guy by a Dr. Stoll, who served in the Continental Army in the United States in 1776. So we do get some additional credit there. Let me just advance the slide here. There we go. This next slide shows the prevalence of HLA-B27, of ankylosing spondylitis, and of spondyloarthritis in general around the world. And as I think you can see, we vary from the Eskimos to China, going down the list. And we see that HLA-B27 occurs more or less frequency in different populations. In places of the world such as Africa or in Japan, it's very rare. But we can see where it is elsewhere. In Northern Europe, it's a lot more common. Among certain Native American groups or among the Siberians or the people at the very northernmost parts of the world, it's very common. And where it's very common, we see a lot more ankylosing spondylitis. I think you can readily appreciate there, although we don't have an exact number of the prevalence of ankylosing spondylitis in the United States. We figure it's somewhere up to about 0.5%. The same thing holds for China, even though they have a little bit slightly higher frequency of HLA-B27. And again, as we see areas of Northern Europe where B27 is more common, AS is more common. You also see in the next column that actually only a relatively small proportion of people who have the HLA-B27 gene ever develop spondyloarthritis. We go a little bit further to the right, and we see that, of course, as you'd expect, since ankylosing spondylitis is a type of spondyloarthritis, or spondyloarthropathy, as some doctors call it, we see the prevalence of spondyloarthritis around the world, and the prevalence of spondyloarthritis in the last column in patients who are B27 positive. And we see that still the majority of people who have B27 don't develop any of this. Now, I'd like to talk a little bit about the criteria that we use to help us diagnose and classify these diseases. And I'm doing it for a reason, because I want you to get an idea of where all of this is going. We've used for many years to make a diagnosis of ankylosing spondylitis the so-called modified New York criteria. They were actually first brought together in 1968, and Dr. Seth van der Linden modified them in 1984, and it still remains the gold standard for the diagnosis of ankylosing spondylitis. And that includes the patient meeting the clinical criteria where they have either low back pain or stiffness for more than 3 months, which improves with exercise but is not relieved with rest, limitation of motion of the lumbar spine both to the side and to the front, and limitation of chest expansion. You have to have one of those and to have a positive X-ray, which I'll talk about briefly later on in this talk, in order to meet criteria for ankylosing spondylitis. Well, I've already told you that ankylosing spondylitis is only one kind of a general group of disease called spondyloarthritis, or as you see there, SPA. And in 1991, the Europeans in the European Spondyloarthropathy Study Group put together the criteria for spondyloarthritis in general, which you can see that a patient has to have either inflammatory back pain or synovitis, like arthritis, in the lower extremities, either knees or ankles or hips, in conjunction with at least one of those other things you see on the screen: alternating buttock pain, sacroiliitis on X-ray, heel pain, positive family history of spondyloarthritis, and the like. And those actually have been well validated and perform pretty well. But that doesn't take into account one important finding that I'm going to be talking a lot more about, and I think it should be one of the take-home lessons of this talk. And that is the fact that it takes somewhere between 7.5 and 10 years from the onset of that inflammatory back pain until those regular X-rays turn positive. So people are going around for 7.5 to 10 years hurting, and often without a good diagnosis. And the people who do a lot of work in spondyloarthritis came to the conclusion that we had to do a lot better. And so there's a group called the Assessments and Ankylosing Spondylitis Group, or ASAS, and just in the past year, and I'm part of this group. I'm actually on their advisory committee. They drew up new criteria, and that includes either having sacroiliitis on imaging, whether it be, but particularly on MRI, which comes positive before the X-ray does, plus at least one other spondyloarthritis feature that is listed there: inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, all the way down the line. Or they can have HLA-B27 and two of those criteria that are listed below. So if you have one or the other of those major criteria, and then one of those things down below, one or two of those things down below, you meet criteria for a new disease. It's not really new. It's some people call it pre-radiographic AS, but it's called axial spondyloarthritis. And you're going to be hearing a lot about that. Well, I'd like to use that concept there, and these criteria, by the way, work pretty well. I'd like to use that concept to move into something else, and that is something that's been going on in the United States for a long time now. That's the National Health and Nutrition Evaluation Survey. And this is something that's been going on since the 1960s in the U.S. It's done by the Centers for Disease Control and the National Center for Health Statistics. And Dr. Michael Wiseman and I, as well as other members of Sparking, have been working with the NHANES group for several years now. And we drew up an instrument that was a modification of an instrument that we did in conjunction with the Spondylitis Association. That's being used now around the United States to get an exact determination of what the prevalence is. And I think these data will be out next year. And I think what we're going to be surprised at is how big a problem chronic low back pain and inflammatory back pain in particular is in this population. And it all the more suggests that we need to be spending a lot more attention on this because of the obvious sequelae if this is neglected. And that's just showing what the NHANES are these trailers that go around the country. They have X-ray machines in there, and they have DEXA machines, and they have medical technologists and blood drawing stations and all these things where they not only look at AS, but they also look at a variety of other health conditions like high blood pressure and high cholesterol and osteoporosis and a variety of other things that cause health problems in people in the U.S. So this is truly your tax dollars at work for something that's very productive, which I hope some of you are relieved by. It's been going on since the 1960s, and what NHANES tries to do is to estimate the number and percent of persons in the U.S. population and designated subgroups with selected diseases and risk factors. It monitors trends in risk behaviors and environmental exposures, and explores emerging public health issues such as axial spondyloarthritis and new technologies. And we've actually incorporated all these criteria that you saw for axial spondyloarthritis into the NHANES study currently ongoing. And like I said, we're going to have those data out next year. That just shows that some guy comes to your door with a computer and he sits down and he does the interview, and they have the trailer sitting somewhere nearby. So all this gets to be done. Now let's try to keep the focus, however, on ankylosing spondylitis today. And this is, of course, the slide of the classic AS patient. This is a young man, and you see stoop forward and with the classic bamboo spine that we see in people with AS. And I'll keep this moving here. And we know that genetics are very, very important in AS. The twin studies show that if you look at the overall cause of AS, more than 90% of the overall cause or is heritability or the genes. Nearly all the risk of developing this disease is determined by genes. That the environmental trigger for most AS is likely to be something that's very, very common. The severity of AS, including the rate at which the spine actually fuses, is also determined by genes. In fact, work that Dr. Brown did, who is my partner in TASC, which we'll talk more about, found that the likelihood of going on to totally fusing and what determines how fast the spine fuses and how bad the x-rays are is 62% of that determination is done also by your hereditary background. In fact, we know that the risk of if you have AS, the risk of one of your first-degree relatives, and the first-degree relative is a mother, father, son, daughter, brother, sister. Second-degree relative would be your grandparents or aunts or uncles. A third degree would be second cousins and the like. And the risk of developing AS in a first-degree relative of an AS case is about 8%. So the good news is that it's not a high frequency of developing AS. If in fact that first relative has B27, the risk rises to about 12%. But still, most of them do not get it. And if you go to second and third degree relatives, this risk is much lower. And if you look at your B27 negative relatives, likewise, the risk for developing spondyloarthritis is pretty low. Now, we know that the 600-pound gorilla for AS is in fact HLA-B27. And it's actually better said, about 90% of people, 90 to 95% of people who have AS will be B27 positive. 5 to 10% will be B27 negative. I can talk about what that means too, because we've done extensive work with that. The other types of spondyloarthritis, B27 isn't quite as common, but it's still there and still very important. And that's down below the normal Caucasian, normal white people. It's about 7 to 8% frequency. And that we're going to show you, in fact, the NHANES study will give you a number of exactly 8% in the U.S. population, because we're HLA-B27 typing around the country in the study. Now, after B27 was first discovered to be associated with ankylosing spondylitis in 1973, a lot of people are arguing, well, maybe it's not AS. Maybe it's a gene that sits right next to maybe it's not HLA-B27. Maybe it's a gene that sits right next to HLA-B27. That's really the problem here. And so I think that was largely laid to rest by work that was done in Dr. Joel Torog's lab at University of Texas Southwestern in Dallas, where he actually took the B27 genes and he put it into rats. And lo and behold, those B27 rats, or they call B27 transgenic rats. They took a human B27 and put it in the rats. They developed peripheral arthritis, and see little swollen paw joints in that poor little mouse. They developed spinal lesions. They developed inflammatory bowel disease that looked just like Crohn's disease, the inflammation of the testes, and skin lesions that looked just like psoriasis. And this pretty much put a lock on the HLA-B27 itself at being very important here. Well, that being said, what does B27 actually do? What it's supposed to do is the following. And you see on the left of the screen there that black squiggly line. That's what the B27 molecule looks like. What it actually looks like is to the right there, that blue set of lines and squiggles, because what's happened is back in the late 1980s, Don Wiley actually determined the crystal structure of HLA-B27. And what B27 is supposed to do is it grabs hold of a little piece of protein, and that little piece of protein is called a peptide. And you can see on the left, that's that little red squiggly. That's a little piece of protein, that peptide. On the right, it's that piece of that yellow thing, and that sits right in this groove. You can see it both on the left and the right. That's called the antigen binding cleft. And what that then does is that that HLA-B27 is sitting on the surface of one of your immune cells called an antigen presenting cell. That could be a macrophage or a variety of other kinds of white blood cells whose purpose is to really constitute your defense against the environment, whether it be tumor proteins or proteins from bacteria or the like. These cells capture those bad proteins, and they chew them up inside, and little pieces of those proteins called peptides are then put in the groove of that antigen binding cleft of HLA-B27, that black squiggly line on the left or that blue squiggly on the right. And what they do then is that they then will hand off that protein to those two cells that just came up on the surface on the right, either something called an NK cell, known as a natural killer cell, or sitting right behind that, a CD8 positive T cell. And those those are other kinds of white blood cells that are in your circulation, they're in your lymph nodes, and they're in the gut, and they're all over the body. And together, they then grab hold of that protein, and they just get really busy, and they make all kinds of other proteins that really rev up the immune response, and they make things called cytokines that I'm going to talk about more about in a minute. Cytokines are very important. TNF, tumor necrosis factor, is a cytokine. We'll deal with that in a minute. And so what happens here? This is we would think, therefore, let me go back here, that maybe the whole thing that causes AS is a person getting infected with something or somehow that bad protein getting in there that then gets picked up by the B27 and causes immune response. Well, that's the most attractive hypothesis, but we've been looking for that protein now for 25 years, and we just haven't found it yet. So some other theories have come up. One of those theories is actually done by one of our board of directors, Spartan, and a member of the medical advisory board of the SAA, Dr. Robert Colbert, and he's found that HLA inside the cell, and there's your macrophage again, the same cell. It's a lot prettier now that you saw on the previous slide. That's what a macrophage is. Macrophages are one type of white blood cell that's very important in your immune response. Well, what happens is that as the B27 is being made inside that macrophage, sometimes it tends to fold the wrong way or to misfold. And when that happens, it sort of backs up, sort of like a toilet gets backed up. And you know when that happens, it flows out and causes all kinds of terrible things. Well, the same thing happens with these macrophages, that it gets clogged up and out flows all this stuff that results in chemicals called cytokines being produced. Like that IFN, that's interferon, like that IL-23, like that IL-17, IL-6, IL-1, on all these other white blood cells. These cytokines are proteins that are, I want you to think of them sort of like gas on a fire. That you throw one of these proteins onto the immune response, and it just really explodes. And they're very, very important. We know that as we're designing new drugs to treat the ankylosing spondylitis and other kinds of arthritis, that blocking this gas is important. And TNF alpha, and it's, if I can, well, I can't move it, but it's the right of the screen there, partially blocked by the little thing, that TNF-alpha, which, your tumor necrosis factor blockers, Enbrel, all that, that's another one of these cytokine proteins that gives rise to inflammation. So so B27 may present some kind of peptide from some external influence, such as an infection, or it may just stick to itself and misfold and cause all this inflammation. Whatever it is, once it takes off and all these cytokines start coming out, we get disease, we get inflammation, and that gives rise to the other stuff that we see actually in AS. Let me just go back to the slide. And I'm not going to spend much time on this slide, just to say that a lot of those little things written in black are cytokines. They're very important immune response that are all basically getting into play in AS. And we're going to talk about some of those cytokines more in just a moment. Now let's move to genetics. And what you're looking at there are your chromosomes. That's what your chromosomes, your units of heredity on which all those genes are contained look like. And what you see is you have 22 different chromosomes. And then there's the X chromosome and the Y chromosome. And the Y chromosome makes you a man, and since we all have 2 doses of the chromosomes, you get one set of chromosomes from your mom and one set from your dad, and then you're going to pass on one of your 2 sets to one of your kids. So, for example, a woman that makes her a woman, she's going to have 2 X's. That's why she's a woman. A man's going to have an X and a Y. And that X and the Y determines the sex of the child. But this is what and we see that the chromosomes are of different size. Some are itty-bitty little chromosomes, like chromosome 21 and 22, and some great big ones, like chromosome 1. That's the biggest one. And so what I've been doing for many years now is to try to find the genes that are associated with all these diseases. What we did first was we used to do things back in the 90s called microsatellite scans. Then we only just used 400 markers to look down. And what that did is sort of look, as you're seeing there's the chromosomes again, and you see those red bars. And those red bars are where we would be mapping. And it's sort of like, I used to say, it was like if you put all these chromosomes together into one continuous line, it was like looking at Interstate 10, going from Tallahassee to Los Angeles. And so this would be like mile markers. Well, the problem was we have since found that if those genes were hiding between the mile markers, we might miss them. So this proved to be a rather inexact way. We found a lot of important information from doing microsatellite scans, but the technology's moved on, and now by 2010 we can look up to actually I've listed 616,000 markers we can look at, so we can, instead of doing mile markers on I-10, we can do foot markers on IL-10, and we can really get a good look inside all those chromosomes that hunt for those genes that are important in AS. Because we know that AS is determined by more than one gene, by several genes. And in doing so, we formed something called TASC, which is the AAA Spondylitis Consortium, otherwise known as the Australian Anglo-American Spondylitis Consortium. It is paid for by your tax dollars, by the National Institutes of Health, and I'm actually the head of this consortium. Dr. Matthew Brown in Brisbane, Australia, where that arrow rests right there, that's roughly where Brisbane is. It's a little bit lower, actually, is my partner in all this, and we're teamed up with Dr. Paul Wordsworth at Oxford in England. That's TASC. And what we've done is that we've actually picked out most of the genes in AS. So this is called a Manhattan plot, sort of like the Manhattan Project. But what you're seeing there, you see it in the color codes down below. You see it's like these bars. You see chromosome 1, chromosome 2, chromosome 3. So chromosome 1 is that sort of, I don't know what to call it is. It's sort of like an off orange. Then the purple one's chromosome 2, chromosome 3, all the way down to the end, little itty-bitty chromosome 21 and 22. We also have data for X and Y, but that was looked at separately. And each dot is a marker, okay? So there's a whole bunch of markers on chromosome 1. Each dot is one of those markers we looked at in the scan. Chromosome 2, chromosome 3, chromosome all the way down. And this helps us to look to find where those genes. Basically, there's a red line here, and this red line If any markers that are above this red line, we know are significant and important. And so when we go above the red line, there's not a lot of those markers left. I'm going to move that down here. So what we're looking at here are markers on chromosome. We got some markers on chromosome 1. We've got some markers on chromosome 2. Move over. We got some markers on chromosome 5. And then we see, well, chromosome 6 is where the HLA region sits. And lo and behold, look at all those markers on chromosome 6. It goes right up off the top of the scale. That's, of course, the effect of HLA-B27 and other genes in the major histocompatibility complex. So it's very clear that that's the 600-pound gorilla here, the MHC. And then I'm going to have more to say about some of those findings on chromosome 21. That you're looking at right there. We had 4 markers on chromosome 21 that lit up as significant, several on 2 that we're going to say a fair amount about, and as well as a couple right around the border here and then here's chromosome 1, chromosome 5. Now, what are those? Well, first of all, we know that most of the effect that we're seeing here off of chromosome 6, the major histocompatibility complex, is going to be explained by the effect of B27. But we have found something else. So what is it on chromosome 1? Well, it's IL-23 receptor. That's what we found on chromosome 1. What about chromosome 2? I'm sorry, it's not going the order I wanted. So we skip from 1 to 5, and that's ERAP1. Dr. Brown and I described this in a very prestigious journal called Nature Genetics in 2007. ERAP1, or ARCH1, on chromosome 5, and that's where those dots correspond to. And each one of those dots is a marker inside of the ERAP1 gene, and then IL-23 receptor gene, which are those dots that you see coming off of chromosome 1. That wasn't the only thing that we found. In another paper, when we completed our genome-wide association study, we found a bunch of markers at a position in chromosome 2. It's a position called P15. That's the position chromosome 2, and all these markers sit right there. And that's what we call, there are no genes there. That's a gene desert, and that contains other bits of DNA that are important in giving rise to things that control how other genes actually get expressed. Same thing we found in chromosome 21. At a particular position called Q22, we found a region of DNA that had no genes, just a stretch of DNA that contains regulatory elements that determines how other genes actually get expressed. Well, in addition to that, we found 2 genes that weren't quite as strong. We found one right in the margin here called the anthrax receptor, and I'll tell you what that is. It's not anthrax. It's just what some guy described it, called it. And the other is interleukin-1 receptor. And so we're going to get back to those in just a minute. Now, as we try to explain that 600-pound gorilla, it's not only B27. We have found, and we've known this actually for 20 years now, that in addition to B27, there's another HLA protein that's very important. It's called B60. As far back as 1989, Bill Robinson and others actually showed this to be increased among B27 positive white patients from the U.S. and Europe. Subsequently, Matthew Brown and also us have seen this in the United States and in the United Kingdom, as well as data that is just coming out for publication soon. We looked in ankylosing spondylitis in blacks, and lo and behold, B60 comes out there. Not only do we see it there, but it also is seen in Chinese. And even in B27 negative ankylosing spondylitis patients, it comes out highly significant. And by the way, we saw this in the B27 negatives also. The only population that B60 has not come out in is among Mexican mestizos. So that it clearly appears to be very important in a lot. It's not in any way, shape, or form as important as B27, but it's important. Now, we talked about that ERAP1. What is that ERAP1? That's that gene that's on chromosome 5. What the devil does it do? Well, you know, as the HLA-B27 picks up that little piece of protein inside the cell, inside the cell we talked about before, in order to take it to the cell surface and cause an immune response, well, what ERAP1 does, it's also a protein inside the cell that actually prepares that bad protein, that protein that causes disease, for being stuck onto B27 into that antigen-binding cleft, so it can go and cause disease. It also trims other proteins in the cell, including the proteins that actually grab hold of those cytokines and pulls them into the cells. So it clearly is a very important gene in causing AS. The other one we talked about was an IL-23 receptor gene, and not only is that's a gene that it's one of those proteins that takes hold of another cytokine called IL-23, and we've already shown that this is not only relevant in AS. Other groups have shown this to be important in Crohn's disease, in psoriasis, and it's all the same single nucleotide or SNPs that are important, and they all go there. They all have the same kinds of association. So this is a protein that's very important, or gene rather, that's very important in causing several diseases that works in conjunction with B27 and ARTS to cause the disease. That other one, that IL-1R2, it's not associated with any other disease. It acts as a so-called decoy receptor that interferes of the binding of another important cytokine called interleukin-1 to its receptor. It sort of blocks that, and it's a polymorphism, a change in this particular gene has caused this this IL-1, this decoy receptor, to also change, so that suddenly now a person's risk for developing ankylosing spondylitis is increased. It's not clear what the anthrax receptor protein, that's otherwise known as capillary morphogenesis protein, CMP2, but anthrax receptor sounds a lot more sexy, and it doesn't have anything to do with anthrax. Okay, we know that it causes certain diseases, but what it's doing to cause AS isn't clear, and that's one of the areas where we're actively studying now. Now, other genes have also come up that didn't quite meet the significance. One is the receptor for TNF. Well, that's like, you all know that how important TNF blockers are in treating AS. So now that we're finding that a mutation in it is further predisposing to AS, especially in Orientals, this is very exciting. These other genes down below are also very, very important in this in the production and modulation of these cytokines, these proteins that are like gas on a fire that get the immune system going. And so that's just more or less, I don't need to summarize that any further because I want to talk about some other issues. Now, let me explain what's happening. The problem is, we didn't know this before, that aside from B27, the impact of each one of these genes in causing AS is by itself very small. When they get together with mutations in these other genes that we have found, then suddenly we start seeing a more compelling picture arise. And so back when we found the ERAP1 and IL-23 receptor association in 2007, we only had about 1,000 patients studied. We got that number up to 2,000, and we got the numbers of patients that we studied higher. Then we started seeing these other genes starting to pop out. Well, we keep increasing the size of samples because we now are looking at patients from Canada, from the U.S., from not only the United Kingdom but other parts of Europe, and new genes are starting to come out. I guess it's sort of like finding the genetics of ankylosing spondylitis. It's like crawling up an apple tree. The low-hanging fruit are the ones that are more important and have a greater impact in causing disease. B27, of course, sitting down on the ground, you can just pick that up. But you just go a little bit up the tree, and the low-hanging fruit was ERAP1 and IL-23 receptor. You go a little higher up the tree, getting your numbers of patients up, then this IL-1 receptor and the gene deserts and anthraxin receptor, all those start becoming obvious. And when we get way to the top of the tree with 4,500 or 4,000 patients, suddenly these other genes, and when they all become apparent, the picture starts becoming a lot more clear what's causing this disease. We've extended this because we haven't just looked at AS per se, we've also looked at uveitis. And many of you who are on this call have been troubled with uveitis. Up to 40% of patients with AS will eventually develop iritis. You can see that really inflamed eye in that fellow in the picture there. We did a scan that you see down below, and that we published back in 2005, but we've now looked within our own patients who had uveitis versus those who didn't, and some new genes that seem to be very specific for uveitis are coming up. This is still very preliminary, and this is done in conjunction with Dr. Jim Rosenbaum and Tammy Martin. In fact, they were really leading the effort here. in conjunction with us. And we still have to determine what's going on in these genetic regions. This is an area of active investigation. But it sure would be nice if we could predict up front which people are going to develop uveitis and which aren't, because if untreated, it can lead to visual loss in some patients. Another thing that you have to keep in mind is that if you were to do a colonoscopy on 100 people with ankylosing spondylitis, up to 69 of them would have evidence of Crohn's disease actually on the colonoscopy, even though they didn't have any symptoms at all. Well, that doesn't affect your treatment, because if it ain't broke, don't fix it. So only those who actually have symptoms of Crohn's disease, like bloody diarrhea, terrible abdominal cramping, and the like, would you consider treating for inflammatory bowel disease. But nevertheless, that tells us that it gives us important clues as to the pathogenesis of this disease. That it may be that in the person with the right genetic background, okay, that this may be the portal of entry, the gut, maybe the portal of entry. In fact, we think that probably is the case. The portal of entry called where the disease starts, because the disease doesn't start when you're born. You're born with those genes, but you don't have the disease when you're born. You develop the disease in the second, third, fourth decade of life. So it's thought that this may be the triggering element. So that led us, because we already have a pretty good idea. There's been a lot of work done looking at the genetics of Crohn's disease and ulcerative colitis. And this is, again, this is another manifestation. This is looking at I10 then, the genes, starting on chromosome 1, 2, 3, 4, all the way through the X chromosome. And these balls there indicate what genes have come out for Crohn's disease. Some of them look pretty familiar, some don't. For example, we knew back in the 1990s this gene called NOD2. That's very, very important in the innate immune response. What's the innate immune response? That's the immune response. That's the immune system that you're born with. Okay. The acquired immune response is how your immune system modulates itself and changes itself as you get exposed to infectious triggers and the like from the environment. But this is what you're born with, your innate immune system. And one of those genes of the innate immune system called NOD2 was found to be very important in causing Crohn's disease. Well, as they then did their scans, other genes popped up. Our old friend IL-23 receptor on chromosome 1 was there. Some gene deserts that we've already talked about. Again, a gene desert is the stretch of DNA that doesn't have any genes in it. It's a stretch of chromosome without any genes. And what lies in those gene deserts are other bits of DNA that are very important regulatory elements in determining how genes get expressed. Okay, so you see a bunch of genes that have been implicated in inflammatory bowel disease. And we've been working with this group. And what we have found, and this paper is now in press, is that several of the genes that have been implicated in inflammatory bowel disease we're now finding in our ankylosing spondylitis patients. And so it's very clear that there are shared genetic influences in inflammatory bowel disease and also in psoriasis, which I didn't get into today. And this, well, I think I've already really mentioned what's in this slide, and that's the fact that not only is susceptibility to ankylosing spondylitis genetically determined, but so is disease severity. And we're actually studying this right now in the TASC profile. This is an effort that's being led by Dr. Michael Wiseman, and Dr. Brown and I are working very closely with him, as well as Dr. Michael Ward at the NIH and Dr. Leanne Gensler at the University of California, San Francisco. And we know that we have already, it's a little too early to talk about it, we've identified genes that are important in severity. Why is that important? We know that if a gene is going to make your ankylosing spondylitis more severe, you've got a new target for therapy. And so this is very, very exciting and just coming out now. So how do we determine severity? Well, we do it by looking at people who have persistent activity of their AS, by those who have impairment of their functioning by their AS, and also by the X-rays. And this is what standard X-rays look like. This is sacroiliitis. That's a picture of the pelvic X-rays, and that's a person with moderately advanced sacroiliitis. You see all the shagginess there along the sacroiliac joints, erosions and stuff like that. And a little later on, you see this is the side view of the lumbar spine, and you see the classic bamboo spine with the calcification of the outer fibers of the disc even, and the fusion of the apophyseal joints in a patient with more advanced ankylosing spondylitis. Well, one area that's getting a lot of attention is MRI imaging, and because it takes advantage of the fact that the average time between the first symptom of AS and the appearance of radiographic sacroiliitis is about 7.5 to 10 years. And the MRI allows you to get in there before the X-rays turn positive. How does it do that? Well, it doesn't do any better than a CT scan or an X-ray to pick up erosions, like we saw in the prior regular X-ray. But what it does, it picks up inflammation, which is manifested bone marrow edema or enhancement on certain images. And you're looking at them there. You can see that white stuff. On either side, there's a sacroiliac joint there, sacroiliac joint there. You see the white stuff at either side of the SI joints. And that is what we're talking about. And that's just another look, because not only do we see that in the SI joints, we can see that in the spine itself. You see at the edge, it's a side view of the spine. That's your tailbone right there. That's the lumbar spine. That's the thoracic spine. And you can see that on the edges of the vertebrae, before the bony fusion develops, that you see all of this white stuff, that inflammation. There you see it again on this particular view too. That occurs in patients with AS. And you can pick this up on MRI, and it's really very helpful. That's just sort of a little bit more of the same. I think it's pretty dramatic. In another patient with AS, where you see an MRI of the spine, and that's by a particular way of they're looking at called stir images. But it's a standard MRI, and you can see the white stuff, the bone marrow edema, the inflammation that's actually occurring in the bone before the fusion actually occurs. Because that's very important after determining treatment. And you've seen this slide before. This is just an overview of how we treat ankylosing spondylitis. And we tailor that to where the patient is having problems. If the problem is primarily buttock pain in the sacroiliac joints, we start with non-steroidal anti-inflammatory drugs. They've shown that they can inject either steroids or even, so there's papers that are out just recently where they'll actually inject things like Enbrel into sacroiliac joints and actually get some relief with the sacroiliac pain. TNF blockers, you know all about. If the pain's more elsewhere in the spine, again, it's pretty much the same thing, although we try to make sure that we get a physical therapy consult in patients with AS. Most of you don't exercise enough. There's a study that just came out that looked at that, and so that's very, very important. At least a half hour a day, 5 days a week. For the peripheral arthritis, we can use things like sulfasalazine and methotrexate, and for enthesitis, like plantar fasciitis or Achilles tendonitis, we don't inject Achilles tendon, we inject some of the other areas of enthesopathy, and that can help. But what ends up happening is they don't help, we go to the TNF blockers. And about 50% of people with AS are going to respond to TNF blockers, I'm sorry, to non-steroidal anti-inflammatory drugs alone. This is very important because at the current time, the TNF blockers will not, as far as we know, slow down the rate of fusion. The only thing that's going to do that are non-steroidal anti-inflammatory drugs like naproxen or Celebrex or the like, taken regularly and not when you feel like it at full anti-inflammatory doses. This is a paper by Wanders et al. That came out in 2005. This study is now they're trying to replicate the study on a much larger scale because of its obvious impact on treatment. But I try to have all my patients taking non-steroidals if they can tolerate it. Now there's 5 different TNF blockers that are out there. We have the first one out that was approved by the FDA was etanercept. Infliximab came soon thereafter for AS. Then Humira, and then it was adalimumab. Last year we had Simponi, which is known generically as golimumab, and Cimzia, which is known as certolizumab. And they've all been approved by the Food and Drug Administration for rheumatoid arthritis. Enbrel is a little different. All these are antibody-based treatments, whereas Enbrel is just a soluble TNF receptor. And it does not work in Crohn's disease, but it works and has been FDA approved in all the others, has Remicade, Humira. Actually, it's now been approved, so I should change that. Golimumab has been approved for rheumatoid arthritis, psoriatic arthritis, and AS, and Cimzia for Crohn's disease and rheumatoid arthritis, although it's still in clinical trials for the other indications. What about what's new and that's coming down the pike? Well, I mean, TNF blockers are great. They've done an awful lot they've really made people's lives a lot better. We still have to do a better job addressing the fusion, and we were talking about cytokines, whether it's cytokine genes or cytokines made by white blood cell or the like. TNF is a cytokine. We block TNF and to get effective treatment of this disease. Well, other cytokines are being addressed now too. For example, interleukin-6, tocilizumab, has already been approved by the FDA for the treatment of rheumatoid arthritis. It's a humanized anti-interleukin-6 receptor antibody, and it is now in clinical trials to see if it helps AS. My own feeling, just from work that we've done in our own lab with cytokines, that probably it will be a very promising place to look. And it has the added advantage of also potentially addressing the bone fusing part of AS. So this is an area that's very exciting. IL-12 has been shown, it's a human monoclonal antibody, ustekinumab, that binds the part of the interleukin-12 and interleukin-23 molecules, a subunit of those. It's already been shown to be very effective in chronic plaque psoriasis and looks promising for psoriatic arthritis. I'm not aware of any data in AS. What I've heard thus far has not been as encouraging as the psoriasis data. It's been shown also to work in Crohn's disease, but only the people who don't respond to TNF blockers like infliximab. However, they also tried it in multiple sclerosis, didn't work. There's one that's just in clinical trials now. They're blocking interleukin-17, which makes good sense when you know the genetic data. And both the drug company Novartis and the drug company Seneca are both have this drug in development, if not in clinical trials. And so this is some of the newer stuff that is coming down the line in that regard. And the groups that you've already heard about, the Spondylitis Association in America, has been deeply involved in not only patient advocacy, but also in furthering research in AS, both by being our partner in the genetics project since 1998, from the original SAA family genetics study that provided the groundwork for what we're doing now, but also with the low back pain screening project, where an instrument has been published that we developed with the SAA just last month, that helps to screen and differentiate people who have AS versus those who have chronic back pain for other causes. The Assessments and Ankylosing Spondylitis Working Group, it's a primarily European group, but some of Americans are part of it too, including myself, that we're trying to determine better outcomes in AS. And of course, Spartan, which is a group of rheumatologists that is focused on the education of rheumatologists and trainees in AS, and as well as working with NHANES to define the true epidemiology and impact of this disease in the U.S. In fact, the whole PSA has really gone back. If you go back just 12 years ago, there were no clinical human genetic studies that was going on in the U.S. And the past 12 years has been a wonderful success story of not only partnership with the SAA, but also getting out a lot of the work that we presented today that is really has us in a very different universe than we were 12 years ago, when we didn't have very effective treatments other than NSAIDs, and certainly didn't know in any way, shape, or form what causes disease. Because this picture is the past, should be the past, and should always remain in the past. This is that classic picture that I'm sure many of you have seen. This is a Canadian World War II veteran with pictures going from 1947. He died in 1974. The difference between 72 and 74 is he had hip replacements. But we see the progressive deformities in the spine. In this particular patient, AS, this is a picture that we really want to be part of the past, not the present, and certainly not the future in our patients with AS. And I think through a lot of the work that's being done now, work that a lot of you have contributed to, either as being parts of these studies or financially or whatever, that bring this effort forward, this is a picture that we should only see in the history books. I think I'll stop here, and thank you very much. I'll turn it over to you.
Okay,
Melissa.
Great. Thank you. Okay, so what we're going to do now is I'm going to open it up for questions. I have a few questions right now about related to research, so please send me your questions. And Dr. Reveille, first question I have is, when do you think genetic testing beyond HLA-B27 will become a common practice for rheumatologists?
It's a good question. We actually, 2 years ago, presented an abstract at the American College of Rheumatology meetings where we looked at actually, this was last year, not where we actually looked at using HLA-B27, using the ARTS1 or ERAP1 gene, the IL-23R gene, those two gene deserts, just looking at them by themselves and seeing that if we could have a blood test that can be done looking at these 5 genetic factors, and we found that it actually performed better than MRI in predicting who would develop the disease and someone with the right symptoms. So we're right now, it's in the stage of patenting and all that, and by the way, I probably will never receive a penny from that patent, but that's just because I'm an employee of the state of Texas, so that's just the way it is. But nevertheless, that is what we're trying to do is we're looking further inside these genes to see if we have a better marker inside the genes than the single nucleotide polymorphisms that we've already determined, so we get the sharpest and most predictive tool. We're also trying to extend this to other ethnic groups. We have a paper going in looking at Chinese, and so I would say within 3 or 4 years, we should have something available.
Okay, great. One question we just received is, what about HLA-B27 negative patients with active AS? I'm negative and feel lost for a reason why I have AS.
Well, this isn't published yet, but let's talk about that. First of all, let's talk about B27 negative, like AS. 10% of white people will be missing with AS will not have B27. 40% of black people will not have B27. Now, some of those will have that B60, but a lot of them won't. A lot of them won't have any particular HLA-B gene that we can nail down. So what about them? Well, when we look at the genetics of those groups, we also don't find any association with ERAP1. So, but then all those cytokine genes come out much louder and much clearer. So you can certainly develop AS without B27. Not only that, but in studies and some of which are still ongoing, we find that radiographically, if you look at people who have B27 positive AS versus B27 negative AS, the people who have B27 negative AS tend to develop the disease at a later age. And they are much less likely to have AS in their family members than a person who has was B27 positive. They also are much less likely to have uveitis, inflammatory eye disease. Beyond that, they're the same. They're the same prognostically. They're the same radiographically. It's this otherwise in severity the same disease. Okay.
Okay, great. Thank you. Do you think that new genes will allow for diagnosis to be revoked for some patients?
No. And this is one thing we have to make clear. This is with any of these tests. When I talk to doctors, and I talk to a lot of doctors, the message I try to always apply is that laboratory testing is only appropriate when you've got the right clinical scenario. All laboratory testing does is to confirm the diagnosis in someone in whom the diagnosis is suspect. That's what they're meant for. And so if a doctor comes in and spends 1 minute with you, then orders a bunch of lab tests and walks out of the room, and even X-rays, he's not getting a picture of what's going on. The most important thing is the history and physical examination. And so I do not see these gene tests debunking this. The B27 story is a classic one in itself, where 10% will not have B27.
Okay, thank you. This is in regard to research trial. Can we participate in research trials? How? Especially for those of us not currently being helped by the various TNF blockers who are willing and eager to try new meds.
Well, let's look at the ones that the TNF blocker trials. Actually, there's some that's still ongoing. There's some looking at people who have pre-radiographic ankylosing spondylitis. Abbott is currently doing a study of that, and I think UCB that makes Cimzia is also planning on doing that. There are trials ongoing by Novartis looking at interleukin-17. The problem with what Novartis did is they up until now have only done I can get, you don't want to hear me get upset online, but they've only been doing their studies outside the U.S. because they don't want to deal with the regulatory stuff in the U.S. Problem is, now they're finding out that unless they tested this drug in the U.S., the FDA is not going to approve them, so they're trying to backtrack. But the IL-17 work with Novartis has only been done outside the U.S. They're trying to remediate that, but probably they won't be able to do it in time. Other companies that are developing that know this, and they're trying to focus in there. And when those trials come available, I know that we usually participate in these trials. We were the lead site. I participated in every one of these trials virtually that we've talked about today, and we do look forward. We're planning on participating in some of these new cytokine marker trials, but we're still negotiating with the companies. What you need to find out is if you go to grants.gov and look under clinical trials that are ongoing, because every clinical trial has to be listed with the government, and you find out not only what trials are ongoing, but which ones are still enrolling. And so you can look it up online, and what you do is you look for a center that is doing the trial that's near where you live, and that can help you to determine the feasibility. Because I mean, when we did the golimumab study, we had people from we're in Houston. We had people from Dallas, from Arkansas, from all over Texas, and even Louisiana that were coming to participate in the study. Of course, you know, if you look at the current cost of these drugs, these people are effectively making $150,000 over 5 years, because that's how much money they were saving by getting the drug for free.
Okay, thank you. Next question. We all know that AS pain comes and goes. I haven't been diagnosed yet, and I'm concerned that the MRI won't detect any inflammation unless it's taken when I am actually in pain. Is that the case, or will the imaging be able to detect inflammation despite the fact that I may not be hurting when it's taken?
The imaging is more likely to detect it if you're hurting, obviously. MRIs can vary, with disease. I mean, that white stuff you saw is a marker of inflammation. And if there's not much inflammation going on, the MRI might be negative. And if you haven't got the point yet where you develop erosions or the other things you tend to see on an X-ray, and there's no inflammation, it's a lot harder to make the diagnosis.
Okay. This next question is obviously from a science guy. You mentioned Dean deserts are associated with the disease. Have you been able to pin down exactly what is there? Non-coding RNAs, promoter or enhancement elements, DNA methylation sites? Any hints from the ENCORE data? ENCORE data. ENCODE data.
Well, we haven't looked at ENCODE. We've been looking in our own work, and we've done some work looking at the currently available panels, looking at least microRNAs, which are the non-coding RNAs, at least one subset of them. And we have not found anything yet in that regard. Obviously, more work needs to be done here.
Okay.
There are other kinds of regulatory elements than microRNAs.
Thank you. Has there been any serious study of the effects of the low starch or any other diet in AS? I am now reading the China study, which blasts the intake of animal proteins, and I'm totally confused about what is the healthiest way for an ASer to eat.
Good, it's a good question. Yeah, because I browse around a lot of the AS websites. I'm just fascinated to see what people think and do with this disease. And there's a whole school of thought that thinks that it's all in the food. But I've seen every kind of subtraction diet applied that you can imagine in patients, and with very discouraging results. There is no AS diet that we know of. That very often we'll see a single study that is presenting work on a certain one kind of diet or another, but it virtually never gets replicated. And so this whole area has been very discouraging because it'd be such an easy thing to modify. But some of these subtraction diets are very, very hard to stick to also.
Are you there?
Yes.
Okay.
Can you hear me?
Yes.
Yeah.
Okay. Thank you, Dr. Reveille. All biologic medicines today block proteins like TNF that aggravate immune response. Instead of this indirect approach, is there any research being done to directly alter the genetic algorithms that produce TNF and other cytokines so that TNF and other immune teasing hormones are produced in normal qualities?
One of my favorite commercials from my childhood was a margarine commercial, and it showed Mother Nature there, and someone did something and she waved her wand, and the guy sort of exploded or something, and then it ends up by saying, "It's not nice to fool with Mother Nature." We're doing a lot of fooling with Mother Nature right now, but Mother Nature very often finds ways of outsmarting us. That if we block a certain protein, or that Mother Nature finds a way of bypassing us. The immune system is redundant and complex. That very often all these pathways, it's not so much the individual genes. I think if you look in the genetics, the Chinese data where they have no association with the interleukin-23 receptor. Instead, they find the other genes in that network. Because these networks mean that it's a gene that talks to another gene that talks to another gene, etc. That it's the network more than it is the genes. It's the sum total of the genes working together than the individual product of the gene that I think is going to be so important here. Therefore, attacking this from a genetic basis will be very difficult. Also, these genes are doing some good things. What if we try to attack B27? Well, people are B27 positive. If they get infected with HIV, live twice as long. They have natural resistance to hepatitis C. And to certain influenza viruses that other people don't have. So it's the good and the bad, and in the end it means trying to modulate the network itself than attacking the individual genes. And we've been very lucky with TNF because we somehow managed to hit one gene that Mother Nature hasn't found a way to outsmart us on yet. I'm sure that will be successful with some of the others, but the overall genetic networks are complex. They duplicate themselves and are redundant, so we have to be careful.
Okay. You said that IL-1 has some significance. How about Kineret as a therapy since it targets IL-1?
Good question. It didn't work. It was looked at by Heibel et al. And a study from Spain, and in the Heibel study it gave marginal results, and the Spanish study gave no results. The problem wasn't blocking IL-1, although that might be a good example of the redundancy of the networks, that the immune response found a way of bypassing it. It seemed to be more problem with the drug. It just was not a very good IL-1 blocker. It's very good for certain diseases, especially some diseases affecting children, but I think AS is a little bit more complex than just IL-1 itself, and that's why it didn't work.
Okay. Does walking 30 minutes a day reduce the disease progression, or does it have to be more intensive exercise?
It's a good start. I would, if that is the best you can do right now, I would start with that. Try to walk fast. It's not going to, as far as we know, reduce the radiographic severity. It's going to increase. It's going to decrease pain overall over time, and it's going to sustain and increase your functional impairment, and it's going to do something else. Look, the effect of chronic inflammation of any type is to accelerate atherosclerosis, okay? And so by getting this exercise in, you're also working on your heart in a good way, and I cannot encourage it more strongly.
Thank you. Do you know how the SNPs associated with ERAP and IL-23R disrupt the function of these proteins?
Well, we don't know exactly, but one of those SNPs, SNPs, that we found to be associated with the disease sits right in that piece of the ERAP1 protein that actually binds to the peptide to trim it to be loaded on the B27. So it's right in the functional part of the protein. So we know that. We haven't determined how it affects the function yet. That is work that is in progress, especially in animal models.
Okay, I have an animal model question then. Are rodent models under development that include IL-23R, ERAP, and the other genes?
Yes, they are. Yes, there are. We have the rat models that is an effort that's led largely by Dr. Joel Torag, but also people like Dr. Maxime Brabant from France. is utilizing. And then we have these aren't B27 mice. These are called proteoglycan mouse models. There are people in Belgium that are working on this. Dr. Tibor Glant at Rush University is working on this, and where they show that a lot of the genes that are relevant to human AS are also relevant to murine spondyloarthritis.
Okay.
And that will allow us to study their effect by, they call them knocking them in or knocking them out, to see what happens when we do that. Either like putting a human IL-23 receptor gene in a mouse, or my IL-23 receptor gene from a patient with AS in a mouse to see how that affects it and the like we did with B27 in the rat.
Thank you. I'm a 35-year-old male with AS and HLA-B27 negative. I had Stevens-Johnson syndrome when I was approximately 10 years old. Could the SJS have been the trigger for my AS? I have a twin brother and I'm concerned about his susceptibility in getting AS.
Yes, Stevens-Johnson syndrome is a nasty thing to have. It's you shed your whole skin, but we're not aware of any relationship to that with AS in general. Like I said, the best evidence we had that the gut is the portal of entry, but that's an area that needs a lot more work.
Is there research that discusses possible connections between the number of women who have AS and also have conditions such as PCOS that see higher testosterone level?
That's a good question, because I do a lot of work in lupus also, and some of these questions get very relevant. But I'm not aware of anything that relates hormones to AS. What's happened is AS acts a little differently in women than in men. And the old idea of 9 men to every woman with AS would go out the window a long time ago. It's more like about 65% versus 35% now. It's still a modest male predominance, but it's by no means what we thought it once was. And it may just be that we're seeing a different manifestation of disease. In psoriatic arthritis, another type of spondyloarthritis, the male-female ratio is 1-to-1.
Okay. Originally, I thought TNF blockers were showing evidence of showing the progression, but now you're saying no, and that NSAIDs are better. Just wanted clarification. My doctor has not said anything about continuing NSAIDs regularly, and I am on Remicade. Thanks.
Right. I have virtually all my patients with AS. I take care of a lot of AS. Okay. I'm also a clinician, along with doing a lot of other things. Some of my people in my division would say a few other things that I do also that I wouldn't appreciate. But at any rate, I try to encourage all my AS patients to take NSAIDs. Like I said before, as far as slowing the radiographic progression, it is the only thing that we know of. 50% of people with ankylosing spondylitis do just fine on NSAIDs alone and don't need a TNF blocker. But what determines severity of AS is a lot more than just radiographic severity. It's also functional severity. It's disease activity. It's what goes on in the hips and the peripheral joints, and all those places that TNF blockers are clearly the superior thing. It's not just in the spine.
Okay. What is the latest information status on the sugar starch's possible relationship with AS? And I think you kind of answered that.
Yeah, again, there is no known association of sugar starch and AS. Okay. Whether it be disease activity or the like.
How useful are imaging studies in determining the rate of disease progression? How frequent should imaging studies be done?
The current recommendation is every 2 years to get standard X-rays. MRI, it's expensive, it's cumbersome, and I use MRI primarily to answer the question, is the problem inflammation or not? Because don't forget, just because you have AS doesn't mean you can't get other causes of back pain. I've seen plenty of ruptured disc in patients with ankylosing spondylitis, or either in the neck or in the low back. I've seen patients with ankylosing spondylitis develop a variant of osteoarthritis called DISH, diffuse idiopathic skeletal hyperostosis, which looks like AS on the X-ray, and you tell by looking at the SI joints. So just because you have AS doesn't mean you can't develop other problems in your spine, and that's where I really find MRI imaging to be useful. Otherwise, I rarely repeat it once I get it. I think the clinical measures of disease activity and functionality are more feasible and cheaper ways of determining whether or not your TNF blocker is working.
Okay, thank you. Will new genes affect how insurances will pay for treatment?
That's a good question. The answer is probably not. First of all, I think that there was a law that was passed by the Bush administration that guaranteed protection of that. If you're in clinical trials, certainly in anything that we do, we have a certificate of confidentiality. But the bigger question is, we don't know the answer to that. We can only hope, since already we have precedent that the government has gotten involved to protect people who've had genetic testing from the impact of insurance. And probably we've had a complete paradigm shift earlier this week in that regard. That I don't think that it's going to be a major determinant of whether or not you can get insured for any condition.
With those who are already significantly fused, have Crohn's disease, is there hope for any kind of reversal or relief from pain?
Oh, well, look, and the only company that had the guts to do this was Abbott. When they did their what was the name of the trial? The Atlas trial. They included 20% of their patients were totally fused, and lo and behold, they just had major relief of pain and increased functionality, even though they were already fused, because the inflammation continues on if you have AS. So I would routinely use TNF blockers in people who are completely fused, but when it comes to reversing this necessarily, we can't reverse bony fusion. I mean, if you're very much hunched forward from your AS, it can be surgically corrected. Osteotomy is becoming more and more in vogue, and it can produce some pretty dramatic relief, as long as it's done by a neurosurgeon who has experience in the area, and there are many of those out there, but we cannot undo fusion once it's occurred.
Okay, and just a follow-up question to that, because we get this question a lot. Does AS burn out?
Yeah, it does. I follow a number of patients who have not had any disease, who are completely fused with no disease activity, no pain, and on no drugs. And all I'm doing with those people is trying to treat secondary complications such as atherosclerosis from chronic inflammation, which does affect the blood vessels, or more bothersome complications such as Cowdy-Equina syndrome, managing the osteoporosis that accompanies AS to make sure we can minimize the risk for spinal fractures and the like.
Okay. Have you looked into injury-inducing AS? We hear that question a lot too.
Yeah, and a lot of people will relate the onset of their AS to a single traumatic episode. From what we can see, though, in studies that looked at large cohorts of patients, that it does not appear to be a significant determinant.
Okay. I was diagnosed with spondylitis in 2004. I've been on Remicade since 2007 for rheumatoid arthritis also. It was confirmed by 2 doctors that I also have lupus. I recently saw a neurorheumatologist who's removing me from Remicade, putting me on Lyrica for fibromyalgia, and is not convinced that I have the other conditions. Is it possible to have positive blood work and not actually have those conditions?
Well, let's see. First of all, 5% of the normal population has a positive ANA test, which is a lupus blood test. Okay, as you get older, that chance even goes higher. Secondly, if you've been on TNF blockers for a while, your lupus blood test will up to 20% of the time revert to positive without you ever developing the disease. Thirdly, a lot of things can give you a positive rheumatoid factor test for rheumatoid arthritis. In fact, here in Harris County, Texas, the most common cause of a positive rheumatoid factor, other than aging, is hepatitis C. People who are who have infected with the hepatitis C virus, which is 2 to 3% of the population, will routinely be positive for the rheumatoid factor. And any chronic infection can give you a positive rheumatoid factor. So you've got to be very careful with these blood tests. It has to fit the clinical setting. Otherwise, they're just going to confuse you. And the B27, I've already told you, B27 is present in 8% of the normal population, and is more likely, only a small minority of people who are B27 positive ever develop spondyloarthritis.
Okay, thank you. Has your research shown a correlation between AS and osteoporosis, and could you help explain the decrease in inflammatory back pain with the application of alendronates? Maybe he's trying to. Okay, thank you.
Well, first of all, you have to make sure whether it's inflammatory back pain or not. There's no good reason. We tried pimendronate. That was another one of these bisphosphonates like alendronate. And actually, there was a trial of alendronate that was done in Great Britain that by Andre Kalin that didn't really produce very positive results. So it has been looked at without any encouraging data. Pimendronate was very popular to be used in AS, but it was 16 milligrams IV, caused a lot of abdominal cramping and the like. But it seemed to work best if you lived in Edmonton and not so well in most other places. And it's expensive and really doesn't give you as much bang for the buck as some of the newer medications do. Osteoporosis occurs in 70% of patients with AS. It's a big problem. It has to be addressed. It has to be treated. We frequently will use bisphosphonates for this. We use bisphosphonates with caution. They have their own side effects also.
Okay. Have you ran across any research that show if low-dose naltrexone is effective in treating spondylitis? I have AS and know of someone who's now running and participating in sports after being on a low-dose naltrexone therapy for 6 months.
That would probably be more for the pain relief aspects of this. Relieving the pain makes you more functional. I try to, as much as I can, avoid using narcotics in patients with AS if I can possibly get away from it, because it creates a whole cycle of problems. Now, most of my patients are not on them. Some are who have much more severe pain. We do try to keep the patients functional for whatever it takes.
Thank you. Is there any research in using stem cells to directly work on extremely damaged joints to regenerate them or build bone to avoid osteoporosis?
Well, we can rebuild bone with standard pharmacologic measures now. That's good. That's very good news. Rebuilding new cartilage. It's been looked at somewhat. It's pretty hard to rebuild a destroyed joint, because when you get the stuff in there and starts making new collagen, it's not always as strong as the natural stuff was. It doesn't always go in the direction you want it to be, and the limited amount of work that's been done here has not been particularly encouraging. It's hard to improve on what Mother Nature has already given you. If need be, you can do it surgically, but that approach. And the other concern I have is that if you look at some of the older stem cell treatments, patients develop sacroiliitis as a side effect of the treatment, so I'd be careful about that.
Thank you. There seems to be conflicting views on whether TNFs should be taken with methotrexate or other DMARDs to prevent developing antibodies to the med. Are you aware of any recent studies on AS to clarify this? What is your view?
I'm not aware of any recent studies, and I don't monitor antibodies to these patients. What I do is when the patient suddenly stops responding to a TNF blocker, I may check this. I did give one patient. I don't use methotrexate for this indication on a routine basis. I have one patient over the years, someone I've been following for 20 years now, actually, where I have used methotrexate in this particular setting. He only had spinal disease from his AS, so methotrexate should not have worked. Methotrexate and sulfasalazine do not work in spinal disease associated with AS, okay? It works for the peripheral joint disease. But I tried methotrexate in that setting, and actually it seemed to work reasonably well, but he was on it for a couple of years. He's still on his TNF blocker now, doing very well, even though I've taken him off the methotrexate.
What are the prospects for generic biological medications?
They're so proprietary that we would hope that would be the case. If so, Embro will be the first to go. These are much harder than just a chemical compound. And because of that, it's going to be a lot harder to make them generic. That said, I I know some companies are going to try to make cheaper ones with time, and hopefully the price will come down because I think the current cost is scandalous. And it keeps rising.
Okay. I know you reviewed this before, but let's just hit it real quick. You mentioned several times that the percentage of positive HLA-B27 testing in Caucasian. What's the rate for African Americans?
It's 60%.
Okay.
And those are we had the largest series of anybody. That's a paper just going in now for publication. But we looked at 50 African American AS patients and found 60% exactly. 30 of the 60 were B27 positive.
Okay. Hold on, I'm sorry. Got a lot of questions. Pomidronate, how do you say pomidronate?
Pomidronate.
Thank you. Was on your slide. Can you speak more about its use with AS, when it's appropriate, more useful for some symptoms?
Well, the person who was championing it, I mentioned this before, the person who was championing this effort is Walter Maksimowicz at the University of Alberta in Edmonton, and he gave some very good data showing improvement not only clinically but also even on the MRIs in patients who were receiving pomidronate. It was given 60 milligrams IV once a month. It was associated with a lot of abdominal cramping. And didn't work so well at other sites. I actually probably should remove. That's an old slide, and I probably should remove that because it's not something that's routinely used. The insurance companies won't pay for it. It's not cheap. It's not as costly as a TNF blocker, but it's not so much in the treatment repertoire as it used to be.
Outside of donating our samples, what can AS patients do to support research into the basis for AS disease and treatment?
Well, being involved in studies is one way. Contributing to groups like the SAA who are actively involved in research is another way. Or sometimes you can work directly with the investigator or university. We investigators can't receive money directly, at least anyone based at a university. There are other ways. Another way that's very important is the extent to which the U.S. has fallen behind scientifically other countries. I think because of the way the scientific budget has gotten washed away with all the other stuff. And so I think working on your congressman to increase spending for research would also be very important.
Thank you. Is AS related to developing other autoimmune diseases? Okay.
Let me explain how that works. This is what I've done for my living, and not just AS, but there's two branches of immune diseases. One of those classic autoimmune diseases like rheumatoid arthritis and lupus and scleroderma and Sjogren's syndrome, type 1 diabetes, multiple sclerosis, and autoimmune thyroid disease. All of these will aggregate in family members who have one or the other. A person with lupus is going to have much more likely to have family members who have autoimmune thyroid disease or type 1 diabetes or even rheumatoid arthritis. Same with a patient with scleroderma and the like. It's well established. But they do not have AS. Okay? But if you look at family members of patients with AS, you see a different spectrum of disease occurring. And these are all diseases that I've already shown you in these slides have common genetic backgrounds, such as uveitis, psoriasis, inflammatory bowel disease, and undifferentiated spondyloarthritis, as I've already mentioned. All very important things that very clearly aggregate and cluster in family members of patients with AS.
Okay. Are there any let's let this be the last question. Are there any studies about ASers having lower incidence of catching or having the flu?
I know that people with AS have a natural protection against influenza. I'm not aware of any epidemiologic studies that have, remember that influenza isn't one disease, it's a lot of diseases. You have influenza A and influenza B, and so it's only going to be certain types of influenza. But in fact, that's why we think certain Native American groups have so much B27. And you see some of these groups up in North in Canada, 50% of them will have B27. We think what probably happened was a big flu epidemic that wiped out most of the B27 negatives. but I'm not aware of any hard epidemiologic data. Maybe NHANES is looking at that. I think there are some H1N1 questions that are buried into the current NHANES effort, and they are also B27 type.
Okay. Thank you, Dr. Reveille. I want to thank you for spending your time with us this morning. I think I got a lot out of it, and I hope our attendees did too. So before we end the webinar, I just want to remind you of a few things. If your question did not get answered, email your question to me at melissa.velez@spondylitis.org, and we'll do our best to have it answered. And we also want you to complete the evaluation of the webinar. The address is on your screen, and you'll also receive a link to the survey in your email in about an hour, but it's www.spondylitis.org/survey. And if you missed anything today, please remember we are going to post the recording in the member area of our website, hopefully in about a week and a half. It takes us a little time to get everything all together. And Dr. Reveille has also said that he would provide his slides so that we can have those as well. So if you want to print them out and take notes while you listen to it again, you can do that. So if you're not a member, I want to encourage you to join to help support us so we can continue doing webinars such as these. And also just because there's so much good stuff in the member area now. This will be the 4th webinar recording. We also have audio interviews that I've done, the archive of Spondylitis Plus. There's a lot of good stuff in there. So so this concludes today's webinar, and we plan on doing many more of these in the future. So if you have any comments on topics you'd like me to focus on for additional webinars, please send me an email. Also check the resources and support section of our website to see what upcoming events we have going on. We have a seminar in New York City planned for April 24th. We're going to be in Boston on June 5th for in-person seminars as well. So have a wonderful weekend, and I thank you for your time. Bye-bye. Thanks, Dr. Reveille.
Okay.
Thank you.